Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast we're looking at the NHS National Neighbourhood Health Implementation Programme, or NHIP. This is NHS England's programme to support the development of neighbourhood health, with 43 pioneer sites across England leading the way to test how integrated neighbourhood teams and neighbourhood approaches can better support patients. To find out what this looks like on the front line, I'm speaking to leaders from two of those pioneer sites. First, I talked to Dr. Zalan Alam, a GP in Rochdale and peer ambassador for modern general practice. Zalan discusses his work in intermediate care and the importance of building trust across care boundaries to tackle frailty and reduce unnecessary hospital admissions. Then I'm joined by Rachel Stead, who's the strategic PCN manager for South Sefton Primary Care Network. Rachel shares the success of their innovative Adverse Childhood Experiences programme and highlights the vital need for infrastructure and funding to ensure neighbourhood working is sustainable for general practice. With both of them, I talk about the reality of integrated working, what the future could hold, and why general practice must remain the cornerstone of any successful neighbourhood model. MIMS Learning Live South is returning to London on Friday the 12th of June, and this year we're pleased to announce that tickets are free to book. This is the event you won't want to miss. It's your chance to boost your clinical know-how, connect with peers from across the UK and gain fresh insights that can make a real difference in your patients' lives. This year's clinical programme covers issues including obesity management, paediatrics, women's health and cardiology. We'll also be running a GP Business Hub stream aimed at GP partners, practice managers and PCN managers, which will be chaired by me. Sessions in that stream will cover practice finance, neighbourhood working, using AI in practice and how to meet the challenges of rising patient demand. Spots will go faster, don't wait. Head to mimslearninglive.com/south and grab your tickets today. And if you come along, do pop over to say hello if you see me. I'm really pleased to be speaking to Dr. Zalan Alam, who is a GP in Rochdale and a GP with a special interest in intermediate care and helped set up the innovative Haywood, Middleton and Rochdale Intermediate Care Team, which is a GP-led service. Rochdale is also one of the areas selected for the National Neighbourhood Health Implementation Programme. Thanks for coming on the podcast, Zalan.
Thanks, Emma.
You're in an area that's part of the National Neighbourhood Health Implementation Programme. It's a bit of a mouthful, that, isn't it? How is that programme working where you are, and what is it involved on your part?
One of my other hats as a GP who was a hat accumulator in his other life is peer ambassador for modern general practice. And one of the roles we have is to facilitate the working for what they call the NHIP program. The process in this, in terms of Rochdale, for my specific role, is to be a facilitator really between the primary and secondary care and working at that interface to help connect the two services better. I'm very fortunate to be in a system which has always been very forward thinking in that regard, and we've sort of already had the building blocks for it. So a lot of areas will come to us in Rochdale and say, "Oh, you've done all this stuff for the NHIP," and we would say, "Well, actually, these are things we were already in the process of doing." What NHIP has been is the catalyst to bring various parts of those services together to create a more integrated approach to everything. And I think that is the bit that's been very powerful in terms of improving things.
Do you think that was kind of the work that you'd been doing before all of this? Was that a key reason why you think you were selected for the programme, because you already had a bit of a track record of working collaboratively? Because that intermediate care service that I mentioned earlier, that very much is a bit of a collaboration, isn't it, across care boundaries?
Yeah, so the intermediate care service celebrating its 11th year actually now. It was a bit of a groundbreaking process where it brought in a collaborative approach across multi-systems, multi-partner organizations with one lead provider. And that was sort of a test bed for the expansion then into neighborhood contracts as well as other things. And because I was already working in that role as a GP in the area, as well as a GP working in the extended role with intermediate care, I was a bridge between the two. And when I originally helped set up the service and recruit in it, served as clinical director, you create relationships, and those relationships, when they're across system, there isn't such a thing as a primary secondary care divide for me, because I just walk across the room and talk to the other person.
You're the ideal person to be doing this, aren't you then? So what have you been doing over the past year, since you've joined this programme? What have you been doing over the past year to really push forward on neighbourhoods, and what's your neighbourhood focusing on?
The main areas which we noticed was actually, in the beginning, there was in sort of events nationally focusing on case studies in uh, examples of neighbourhood working. And Rochdale was presented as an example of that in Manchester for intermediate care work we've done. What I found most powerful as a GP was sitting there across the table and how much of our case studies and shared experiences were the same throughout the system, and how much it upset us to see patients who had not received the quality of care we would like. And Rochdale is an area of significant deprivation. One of the particular areas we noted was to do with frailty and the number of people who were attending hospital in the last year of their life, potentially unnecessarily, and in a way that shows that if we had a more integrated approach and the system was talking to itself in a better way, we could actually have a bigger impact. I mean, that was one of our areas of focus. And for me, that area was then triggered off a series of conversations and something which I helped organize with the support of the ICB and the Primary Care Academy, which was a masterclass in modern general practice in Neighbourhood for the area. So we had all the practices in Rochdale attending this. And that was sort of the culmination of some of the work I was doing. But a lot of the smaller impacts were simple things like linking up a community frailty hub with the hospital community hub so they had a better communication. Creating a simple step-up pathway from the hospice to the virtual hospital at home, so that patients who were in the hospice but needed a bit more support could be stepped up and stepped down more easily. It was about impacting on improving patient flow and sort of helping accelerate discharges from the hospital, where you had patients who were going into hospital now who are not staying in unnecessarily, ending up deconditioning and essentially becoming over medicalized, over treated, and over diagnosed to the point where they're now worse than they were when they went in.
How have you got everybody on board with this? Did it help by being selected for the neighbourhood implementation programme? Was that kind of a bit of a boost to people, and people thought, okay, right, fine, we've got to make a go of this?
Yes, uniquely, Rochdale was quite ahead because innovation sort of being the mother of necessity. Rochdale was originally a site which had an A&E and a full hospital, and it was reconfigured around 15 years ago where it lost its A&E and it essentially had one ward. So by use of the intermediate care service and then integrating it, and during COVID, additional elective works, plus the way it was designed, it had to innovate and create more community services in other places. And those were often acute led. So the leadership at the acute level provided system leadership together with the local authority. That meant that they were very much collaborative and sort of driving change forward.
Do you have voluntary organisations that you work with, and what are they, and what are those people doing?
Yeah, so we have a great voluntary sector grouping, and I think they're one of the areas we've identified that we would like to really embed within the neighbourhood working is to establish a structured approach to dealing with voluntary sector. They can often get neglected is probably a harsher word, but I think the sense of a lack of understanding of the challenges they face to do with issues like funding and mobilization. And I think also what we decided was our voluntary sector lead Estelle, what she's done is she's created a regular check-in point for all of us so we can just share things. And she'll say, "Oh, what does that mean?" I'm like, "Listen, please stop us medics because we love our jargon. If we can't explain it to you, there's nowhere we're going to explain it to our patients." So, and that's been very powerful. We've identified particular areas with social isolation and targeting the culturally sensitive as well in terms of sort of the BME communities and looking at sort of ways to promote health proactively. We have significant pockets of deprivation among the BME communities where issues like diabetes and poor diet are big from a proactive health point of view are major challenges. One of the local federation area groups have actually set up for doctors who want to volunteer in the area in Rochdale and sort of give back to the service. I think that's one of their projects, as well as one of their other projects was to create a care home and frailty network amongst the various lead GPs across the area as a way of bringing things together. And we couldn't do that without involving the voluntary sector.
Are you having conversations locally about what people call the left shift of services out of hospitals and into the community? Is that a big part of what you're doing, or is it just something on the side?
I think the answer to that is sort of twofold. One answer is the biggest problem with left shift is the tendencies for the system to go rightward, and you're having to sort of shift that sort of bolt in a different direction, and it's a very hard one to do that, especially if the financial flows don't follow, because you will get initial engagement, and then if the financial flows don't follow, you will see a loss of engagement very quickly because a lot of people are doing things out of goodwill, and goodwill has a finite time to it. There has been a lot of work with outpatient redesign, And there's also been a lot of work with sort of looking at community services. But I think because we're in such a turbulent time in terms of transitions with ICBs and services, it's a lot harder to probably make those shifts and changes than one would have thought. But there is a desire for it. I think that everybody you talk to says, yeah, we have patients waiting for a 1 year neurology appointment. Why can't we just set up a GP with extended role clinic in the community? Why do we have to wait for X, Y, and Z for a memory clinic assessment? Can't it be done in the community? And the answer is it could be done. It's just how do you bring the financial flows and the system together with all the governance arrangements in place quick enough?
The government published its neighbourhood health framework, and there's been some new guidance on commissioning from NHS England about how this is all going to work. It's all quite vague still. There seems to be this plan to just let local areas kind of do what they need to do to make a difference. Do you think that's the right approach for it all to be kind of decided locally, or do you think there needs to be a bit more structure to it all?
There is a real advantage to it when you devolve locally, but it depends on the level of maturity in the system in each neighborhood. So some areas will be prescriptive and others will just be broadly, you can give broad outlines. The challenge will always arise when you mix the two up. When you try to be prescriptive to the areas which have a well-developed system and you have an overly vague one to areas which are lacking in maturity. And once they reach a certain critical point is to know when also you have to step in and step out. So if you wish to address it locally, you have to have a very dynamic approach. And the old system with its sort of 20th century approach of being quite static doesn't really work, I think, in this modern times. You need very dynamic and very adaptive systems that can flex in and out at the right time.
The other thing that we still don't have at the minute are these new contracts, single neighbourhood provider, multi neighbourhood provider contracts. How do you think those contracts will affect what you're doing?
I think there's three layers of anxiety that come with these new contracts. The first one is the single neighborhood contract and how that will affect alignment with PCNs. And I think you can safely say that will cause some destabilization, particularly in areas where you have donut PCNs or orphan practices. But that alignment, I think, is inevitable. You have to align closer to neighborhoods for it to work. And that means perhaps you'll have practices that don't necessarily get along but have no choice but to get along, which is, I think, more realistic than sometimes what we end up doing with these sort of odd arrangements, is for the lack of a better word. And then at the multi-neighborhood, what you're seeing at least a sense of like, okay, well, ICBs are, this is my reading, ICBs are stepping back in a way and becoming closer to what the old SHAs were with strategic health authorities. And that means that there is a vacuum at that level. And I don't think every area has a clearly defined approach to that. Some areas will have federations taking the lead, some places will have acute trusts, some areas will have a combination of different things. We will have to see with time how that goes. And the final bit is with the IHOs. I think that is the bit which is probably the stickiest point for primary care, where it has to be driven by an NHS organization. And to be honest, I understand the reasoning for that because of the amount of money and resources you're talking about. It can't be done by just a small organization. But there's like, well, are you going back to the same organizations that couldn't deliver X, Y, and Z to then decide on these outcomes? I guess it's a question of whether good intentions and well-meaning versus resource and power, and that's like an age-old tension, isn't it, in any system?
Is that restructure of the ICBs causing a lot of difficulty locally? Because obviously, people leaving who would probably have been working on this, and there's, a lot of tensions in ICBs at the minute. Do you think that's going to make this stuff harder to do over the next year?
I think there's two parts to it. One is it depends on how strong or what state the other providers are in the area, the local authorities, the GP leadership, and the acute trust. In our area, the ICB and the acute trust are going through significant changes. So there's been a new federation. So there's a lot of change going on right now. And I think that's a real challenge in any organization which is going through a restructuring. No matter how good the leadership is and dynamic, there is going to be an element of how do you manage the perception of power and status. I think the second part is I personally feel like, at least in this area, we're going through a generational transition where people who were involved in the CCG era and the end of the PCT era, a lot of them have reached a stage in their career where they're choosing to call it a day or transition to different roles. And there's a real loss of organizational memory across the system.
With being part of the National Neighbourhood Health Implementation Programme, or NHIP, I suppose I should start calling it because that's a bit less of a mouthful. What actually does that involve? Do you get extra support or extra guidance from NHS England to do this?
Yeah, so the ICB has a reporting mechanism towards sort of to feed back to the NHS England, And often it's updates where we provide like updates on what things we've achieved and accomplished. And one of the interesting markers they use is to assess the level of trust and collaboration within the system, which Rochdale actually repeatedly scores very high on. It's a unique system in the sense that historically it's a very flat hierarchy. People in positions of leadership have tended to be very accessible, and this is something which I can attest to. In the hospital, it was not unusual for the medical director to just walk in and have a chat with somebody, and there was a very high level of visibility and high level of accessibility, which creates the ability to sort of quickly and very rapidly address issues. I've been accused on occasion of doing too many corridor conversations to address problems and sorting them out, like before they're actually in a meeting, and quickly like, okay, this is what you do, and like, can we do this? Can we do that? But that is an historic thing with our service, and I think one of the trends that we've picked up in our reporting and feedback we get is there's a high level of trust within the system and a high level of collaboration.
What are some of the big challenges that you've kind of encountered from doing this? Where do you think the big sticking points are?
I suppose they're multi-level. One is that you have the challenge of PCNs and practices where if they get involved in proactive care, are they losing resources which they could reinvest in their practices? That's one side of it. And yes, it's really important to do proactive care, but equally you have to pay your bills and you have to balance the two out. So that there's one element. So how do you incentivize that in a way that actually reduces the pressure? The other one is, as far as myself is concerned, I would say if you're not going to be able to impact the large amount of admin burden on practices, then what's the point? So if you have to give them some incentive, and for me, that was as a principle, it's either you call it a one front door or no wrong door approach, where when you refer into the system and then it's bounced off from right to left and left to right, what have you achieved? You've just generated activity with any outcome. So if you don't address that part and you don't eliminate those bottlenecks in the system to make things flow more smoothly, you're going to have a problem. The second is how do you retain organizational memory and create a new generation of leadership that can lead and also have the skills that are more flexible or adaptable for the times that we're in. And I think then the third challenge is what we mentioned about the loss of organizational memory and that worry that we're going to miss key things or just repeat the same mistakes of the past without actually reflecting on it. I'm someone who tries to balance out the fact that activity doesn't mean outcome. It doesn't actually deliver a result, but actually going back to the same thing where you have these perverse incentives driving more and more activity into secondary care, but the secondary care system actually can no longer cope. And there is no other place for them to go to because you've not allowed the financial flows to shift. So the perverse incentives have to be broken, really. And that has to go down with a simple process of the core medical bit, which is the final part for me. And that is something which, for my intermediate care days, I've always tended to break it down into the Ds. It's all about demedicalizing, deprescribing, dealing with dementia, dealing with doctors, and dealing with death.
What could the government and NHS England do centrally to kind of make some of this stuff easier?
It's a hard one, but I think the main thing that would help in the short term would be an element of stability and like consistency in the system.
Oh, yeah.
It's like an underrated gem to everything. And like if you can't deliver a consistent and within reason predictability within a system, how are you supposed to then deliver transformation? Even if you do deliver a transformation, it won't have any sustainability because someone else will walk over it in the next day and just say, "Oh, I think we could do it differently," and then it'll be just reorganizing things again. For me, those are the basics right now. In the immediate sense, I would say sustainability and predictability, get the core concepts of what you're trying to achieve right clinically, and also be humble enough to bring on all your partners, everything from pharmacy to dentistry to optometry. They have to be a part of this process. Try to use one estate, one care record wherever possible. At its core, make things easier for the GPs, because if you don't, then what was the point?
The other thing that seems that's always going to be a challenge with this is buildings and estates. And like, if you're going to move care out of hospitals into the community, if you're going to do more stuff locally, where are you going to put the people who need to do this? What are you doing in your area about estates? Are there discussions going on about how you're going to build a neighbourhood health centre? Do you know what's planned about that?
There are definitely discussions. I would say early days. There's a lot going on, and I think this is a broader part of the system issues where potentially in the past there have been estates which were either the contractual systems and the rental arrangements were so messy that really even though on paper they were meant to be a one integrated side, they were often underutilized, under resourced, and they didn't really achieve what they were meant to achieve. until you again get those basics right of like, what are you trying to do here to deliver sort of improvements for people? If you can't do the basics, and if practices and pharmacies and other places are struggling to pay the rent because it's overpriced, or in a setting where it's basically not really fit for purpose, essentially, if you're going to do something, you want to address these core points. From a care plan perspective, Greater Manchester is in a very fortunate position. We have the Greater Manchester Care Records, and that is providing us a template for like an integrated care plan across the system, which we're trying to improve the rollout of this sort of from intermediate care and secondary care, drive that incentive to, rather than make it just a GP issue, make it a point of reference for all the services and for out of hours care and everything else. That's something which we're very fortunate to already have the infrastructure in place, which we now need to expand on. All the GP practices and the hospitals have access to it. North or West Ambulance Service has access to it. I think in an ideal world, would want to expand access to dentistry and to other parts of the system as well as optometry, because I think that would free up time as well for people like that. And the voluntary sector, again, it has to be involved at some point, but then you have to also balance usual information governance issues as well.
What key bits of advice would you give to other GPs, other healthcare professionals doing this work, trying to get neighbourhoods started, trying to integrate care?
I think the best thing is to have a really powerful or really effective, like what we have in Rochdale, is a bridging team where different parts of the system contribute staff and make it one integrated team to allow for data analysis. And that team that can then facilitate sessions where you're pulling all parts of the system together. And if you have that element of building trust between them and you have created those relationships, a lot of magic then happens without you having to do much. They sort of start conversations, they reach out, and it's just amazing because you're like, oh yeah, that's so and so, I know them. You're no longer looking at them as, oh yeah, they're from the acute trust, they're from the primary care or whatever else. That middle management team where you have that point of connection where you can facilitate things. Basically, for anyone else who wants to do that in positions of leadership, it does require a bit of intellectual humility to accept that you don't have all the solutions in your hands. And it requires some genuine listening to ideas from other places and a little bit of people or understanding where you're coming from and the challenges you face. And it's something which I've been saying for years with intermediate care, is that I would sit in meetings and I would say people would use the same word and it would mean something totally differently. The number of times I would say, oh yeah, this person is fit to be discharged from hospital, I'll be like, fit for what? Is that not the same as being optimized or safe to go home? Until you establish that shared understanding of what those words mean and a shared, even your own jargon or language, then until you get to that communication barrier and you've dropped that and you have a high level of trust, then things start to work.
I'm really pleased to be joined on the podcast now by Rachel Stead. Rachel is the Strategic PCN Manager for South Sefton Primary Care Network, where she leads strategic development and transformation initiatives to enhance general practice sustainability and patient care. Sefton is one of the areas that was selected for the National Neighbourhood Health Implementation Programme, and she's leading on a lot of the work going on in her local area. Thanks for coming on the podcast, Rachel.
Hi Emma, thanks so much for inviting me. I'm really pleased to be here.
How is that programme working and what's involved on your part?
It's been working well. I guess we've seen that, the Pioneer has been an extension of what has been happening in Sefton for years, but it's been an opportunity to think about what we might want to look at going forward. How do we need to evolve our ways of working? Perhaps inevitably, PCNs have been really actively involved in looking at what the Pioneer programme should be doing. And I think we've been seeing some quite interesting new pieces of work evolving that perhaps haven't been active in Sefton before. So particularly around, children and young people, there's been much more of a focus in the Pioneer about how we develop services for children and young people. I suppose what we've been seeing is a bit of a combination of some quite new activity that we haven't done previously, but also using the Pioneer to build on what has already happened and perhaps evolving some of our pieces of work and ways of working to fit the ambition for neighbourhood health in the future.
One of the criteria to take part in this programme, Species Let Selected, was to already have a bit of a track record of integrated working and working collaboratively with colleagues in the area. What were you already doing before you were selected to be part of the programme?
I've always felt that, coming into Sefton, there was evidence of a really strong partnership across partners within Sefton. There was ICTs, integrated care teams, had already been established and have been working effectively. We've got a really strong community voluntary sector in Sefton that does have voice in how we deliver integrated care. Sefton's it's only got 2 PCNs, so between us we cover a footprint of about 250,000 patients. So we had 2 big PCNs that are also mature and used to working at scale. Because of that sort of history, we have been used to, in the PCNs, being flexible, be able to test, pilot new ways of working.
What's kind of changed since you've been part of the programme?
Yeah, so I think it's been really interesting. So some of it is just building on what we've already done. Inevitably, there's been a focus on frailty, particularly with our colleagues in the north, and that fits in clearly with direction of travel in terms of the longer term plan. And that has been embedding. So in South Sefton, we've had a piece of work ongoing around frailty, and particularly thinking about people who are frail but living in their own homes, and we've been able to extend that and really think about perhaps about how we measure the outcomes of that work. But I think for me, some of the really interesting work has come out of things that we have been doing for the first time. So we've been piloting a children and young people's multidisciplinary team, and that's just, I mean, it's in its infancy. We've spent quite a bit of time building what that MDT should look like, and we've had heavy involvement from some of our local primary schools in delivering that children and young people's MDT. That has been a completely new piece of work particularly for our PCN. We haven't really ever built relationship with schools, but seeing how schools can deliver some of the work and thinking about things like how do we work collectively to improve children's attendance at school, because we know so much about the outcomes for kids and the poor outcomes for kids that have high absence rates. So we've been thinking particularly, there's quite a big need around asthma and uncontrolled asthma, particularly in some of our more deprived neighbourhoods. So thinking about how do we work with schools to improve asthma control has been really quite an interesting piece of work. I don't know that we would have done that at this time if we hadn't been part of the Pioneer, because it does give you that chance to think about what should we be doing differently, which relationships do we need to build, what are we doing for cohorts that we perhaps haven't really focused on before.
Is that how you've kind of gone about it, looking at it and go, right, okay, we're going to do neighbourhood working. What is it we want to get out of this for our patient population? Is that the starting point, and then you try and build from there?
I think it has been some of the starting point. And I think we've also tried to use it as a bit of an opportunity to deal with some things that we know have been a problem, or that perhaps partners have thought of being a problem. So things like the children and young people who attend emergency departments with asthma exacerbations. There's always been a bit of a theme around that in South Sefton, and perhaps a narrative that that's because children and young people aren't having up-to-date asthma plans and aren't attending GPs for reviews. Some of the problems that in general practice, we know that it's not about us not trying to reach out to these kids. They all have asthma, invites for their asthma reviews, but they don't attend for whatever reason. And actually being able to spend some time thinking about, we've known this has been a problem for years. We've talked about it a lot. Perhaps the Pioneer has given us a chance to take some of the time to think about, well, why is that? And who do we need to engage in helping us to address that problem? I mean, I would also say that it's not entirely about a Pioneer. This programme did come with a pretty small amount of funding. But I think one of the challenges for me about this Pioneer is actually, in order to get that off the ground, a small pot of funding has made a big difference.
What's going on with the hospital? How does the local hospital trust, how has that fitted into what you're doing?
So Sefton is perhaps quite an unusual place. It's quite a small place, but with multiple acute providers within the Sefton footprint. And we have a different acute provider in South Sefton than North Sefton. But we have had input from the acute providers in both ends of the patch. They are involved in thinking about how do we deliver. So, for example, in South, we have a shared community geriatrician that has supported us in delivering some of our frailty work. I think in reality, it's still a developing area for us, is thinking about how we are working more closely with secondary care providers, but they are part of that conversation, and we are thinking collectively about how do we deliver a frailty service within a community setting. And for us, that's partly why, predating the Pioneer, we had set up some of that work, because there was quite a clear priority around older people being discharged from hospital and we had a really high rate of readmission. So thinking about how can we work together to reduce readmission rates, what can we do before patients are discharged home.
When we met before, it was about your role in the PCN. And I mentioned at the start there, like one of the things that you feel quite strongly about, I think, is that the primary care network needs to be something that supports the practices and helps make general practice more sustainable. So what do you think the impact of all of this is going to be on the GP practices in your patch?
I suppose my ambition will be that almost general practice might not notice. And some of my thinking behind that is, at the moment, GPs make all the referrals, and some of those referrals are, very sensible. If someone needs a speech and language assessment, no GP is ever going to decline to make that referral. And actually, if we get ICTs or integrated neighbourhood teams working effectively that are able to take ownership of coordinating care, it shouldn't need a GP involvement to say, yes, I will make this referral. So for me, some of the really good outcomes of this would be GPs almost being less involved, certainly in the things that they perceive that they don't need to be. And some of my other conversation has been about, if we get neighbourhood health right, at the moment we spend so much of our time talking about referrals and rejected referrals and reasons for referrals to be rejected. And those reasons will be, in a lot of cases, valid. For me, neighbourhood health working effectively would say we see far less rejected referrals, and that we have teams that think more about what this patient needs in order for their care needs to be met.
The government recently published its neighbourhood health framework, and there's been a bit of guidance coming out of NHS England, but it's all still really quite vague. Do you think that's the right approach, or do you think there should be more guidance from the centre?
In my experience, with caveat, that is the right approach. One of the things that we did early on in our PCN was we participated in the Complete Care Communities programme. We were given a pretty small pot of funding, and the premise was that GPs know what is needed in their area. There were no KPIs. There was a commitment from us that we would keep the programme updated with what we were doing, what we were learning, what risk we'd identified, what help we needed to mitigate that risk. But actually, the freedom to work out what we were doing with this funding to meet our patients' needs was significant, because we didn't fear failure, because there weren't KPIs that meant that if we didn't achieve them, this funding was going to be taken off us. The freedom from failure, or if we failed, there was an acknowledgement that we would learn something, and whatever we learn would still impact and improve patient care and patient outcomes. That allowed us to innovate in a way that I think we rarely see, even in primary care, even where there is the flexibility, the responsiveness. We don't suffer from lots of bureaucracy. That for me was a fundamental shift in the way that we worked. And out of that came some really innovative work. The ACEs Adverse Childhood Experience Recovery Programme we adopted into the primary care network because of that. We continue to innovate. This week, we've just finished a children and young people's programme in a sixth form college. One of those on the programme was expected to be dropping out of college. Everyone will know the outcomes and the impact on a young person of dropping out of college not into education, employment or training. As a result of being on that ACEs programme, they have stayed in college. That is a life-changing outcome for one young person in one sixth form college that was born out of our ability to innovate in a way that we weren't fearful. And I think if we could adopt that principle across neighbourhood health, I think healthcare professionals, they know their patients, they know who they're working with, we know what they need. Having said that, it came with funding, and we are talking seed funding, but I think it's fine to have that idea of let neighbourhoods figure it out. But where I think the gap is at the moment is in some of the resource and infrastructure to enable that innovation to happen.
That ACEs programme, so this is Adverse Child Experiences, isn't it? How does that work?
So it's a programme that we adopted from the local authority, and I guess that's testament to that partnership. So it's a 10-week programme. People who experience adverse childhood experience If you have 4 or more adverse childhood experiences, you're more likely to get cancer, you're more likely to die by suicide, you're more likely to get severe mental enduring illness, you are more likely to have heart failure, obesity. If you have 6 ACEs, your life expectancy is 20 years less than someone that doesn't. It might happen pre-birth, some of those adverse childhood experiences. They're happening in your early years and they impact you into your frailest of frail years. People who are 70 plus who had more than 4 ACEs are more frail than their counterparts. We have a 10-week programme. There's quite a lot of engagement that really is about people understanding the impact of ACEs on things like coping strategies and perhaps forming unhealthier coping strategies that then impact on outcomes. So, people are more likely to things like smoking, drinking. So really the programme is about trying to enable people, empower people, build self-esteem, help people form healthier strategies. So as a result of that programme, we have seen people, for example, leave long-term unemployment and re-enter workplaces for the first time. We have seen people take on physical activity, people have returned to education. We have people volunteering with the PCN as a result of going on that programme. And it has been genuinely transformational for so many of the participants in that programme. People self-refer now because they see the change in their relatives and their friends and want to join that programme. And for me, ACEs is an example of neighbourhood health at work, because people that go on the ACEs programme are also offered the opportunity to have a health check, because people historically might have either feared speaking to a healthcare professional, are less likely to have participated in things like chronic disease reviews, less likely to take up screening opportunities. So we give people the time to understand about their own health, why screening is important. So we've had people who have been more effective in being able to advocate for themselves with healthcare professionals. So have been able to achieve things like, significant weight loss. I think it's a fantastic example of neighbourhood health. And it arose out of £40,000 worth of funding about 5 years ago, and has become quite a significant priority across Sefton. As I say, we've now extended that into a children and young people's programme. But it started with, you do what you think is right for your patients. And it was born out of that idea that actually most people know what they need. Most of us know what sort of healthcare professional we need, how we think our needs should be met. And really, ACEs was born out of that idea of enabling people to connect with what they think they need in order to address their sort of health and wellbeing needs.
It's a really great programme. It's just, I think it's such a good idea as well. Because, it really plays into that prevention agenda as well, doesn't it? About stopping people getting more sick later on down the line.
Yeah, and also about how people are prevent passing on their ACEs to their own children, because it is intergenerational. And for me, again, some of the challenge about how do we measure the impact of neighbourhood health is people going on a programme now who say that they are parenting differently as a result of that programme. They're stopping passing on ACEs to 1-2-year-olds. Those 1-2-year-olds are less likely to get cancer because they have less ACEs.
Yeah.
They are the sort of outcomes that will outlast all of our lifetimes. Some of the challenge for me is the real push for this quantitative, these are the outcomes, but actually the qualitative stories are huge. People who have lived with agoraphobia, who start the programme, we will send a taxi to get people because they are unable to leave the house. We will meet those people in the car park so that they walk into a building with someone, being able to walk to the bus in week 10 and independently make their way to a venue. The power of that qualitative story, how we capture that is the exciting thing about neighbourhood health, is that we can see it being transformational, but we have to allow the space to enable to innovate like that and also to fail. It has worked. There still would have been outcomes even through failure. We would have learned, and there are things that probably haven't worked along the way, and you learn from those and you respond quickly. And again, it's such a circular thing. But I'd say I think it's about creating the space to enable some of that to happen.
Yeah. And that's really hard, isn't it? Because people are so busy and everything's so stretched. And I suppose that's one of the things I wanted to ask you about resources, because obviously alongside all of this, it's a massive change the government is kind of hoping to deliver across the NHS. But at the same time, we've got ICBs being significantly scaled back. We've got people losing their jobs. Do you think the cuts to ICBs are going to affect how you develop neighbourhood health in your area over the next couple of years?
Without a shadow of a doubt, it is my biggest fear for neighbourhood health moving forward. I think the role of place colleagues has been absolutely undervalued. I feel so strongly about this that I genuinely wonder whether we will be still talking about neighbourhood health in a year's time, because I think that place colleagues are the conveners of neighbourhood health. You know, some of what I've described, like the ACE programme, it's a brilliant programme. At the moment, it's done through goodwill. It needs people who are the conveners of neighbourhood health. And I've always thought that's the ICB. And that's certainly the way it's worked in for Sefton, is that those roles have been really critical. I think when you think about the healthcare landscape in particular, you know, often providers cover more than one area. There are not many people within neighbourhood health that are really focused on those neighbourhoods. And ICB colleagues, place colleagues, are a really important part of that. For me, you know, the Darcy review said the NHS is undermanaged, and I think it will be even more undermanaged. And I think, you know, providers running on goodwill, because there isn't any funding, there isn't the infrastructure, there isn't the policy direction. You know, I think the PCN contract, the DARES, has actively detracted from neighbourhood working. I think there is just not going to be enough infrastructure left in place. There is not going to be people to continue driving forward some of this innovation.
I've always thought it was going to be quite challenging to do it without people in ICBs. And not just that, though. It's things like this big shift towards using more technology and rolling out AI and things like that. I mean, I don't see how you can do that, really, and expect all the providers just to do it themselves.
Yeah, I mean, we've had that very conversation this week. You know, the technology doesn't support neighbourhood health, and I think is a long way off supporting neighbourhood health. You know, our systems just don't interface. We're thinking about children and young people's MDT, that is even more complicated. How do we look at school absence data and reconcile that with health data? You know, the data sharing that we've needed to work through has been really complex, let alone which systems you record on, because the systems don't talk. Are we recording this on school systems? Is it going into a community system? Is it going into a general practice system? Who's responsible? It's the same with estate. Estate is an enormous challenge in South Sefton. There's really been an underinvestment. I don't know who's going to drive any of resolving some of those really acute challenges. We haven't got enough estate for our staff as it is. How do we recruit the people? Where are they going to be based?
You said that the PCN DES hasn't really helped enable neighbourhood working. Why do you think that is?
So the repurposing of the capacity and access improvement funding, that gave us some flexibility to think about how we delivered access, perhaps in a more innovative way. I think that the retraction of funding from primary care networks has made us focus, and alongside the contractual requirements around urgent on the day, has forced us into thinking much more inwardly around how do we now meet those contractual requirements. ACE has been brilliant. It is not going to have an impact on what we are doing urgently today.
It's always going to end up taking priority, isn't it, for the GPs? If their practice is at risk, that's always going to be their priority rather than the bigger things outside of it, to a certain extent.
Ultimately, my priority as a PCN manager is sustainable general practice in South Sefton. You know, I am totally committed to partnership and system working, as are my colleagues, but none of that will exist if we don't have sustainable general practice in South Sefton. I think the whole contract, this whole focus on urgent, and it goes throughout NHS policy around urgent and elective recovery, it is the polar opposite to the intention of neighbourhood health around proactive care that is likely to see outcomes over a longer term. Neighbourhood health doesn't deal with the today, and the general practice contract has mandated you deal with the today.
That's a really good point, actually. You've made that point very well there, I think. In terms of the other things that are sort of going on around neighbourhoods, you've mentioned estates. as being a real challenge. Everybody I've spoken to about neighbourhoods thinks estates is going to be one of the real sticking points with all of this. Are there any other challenges you see to this work? And is there anything the government can do to kind of unstick some of these problems, do you think, to make it easier?
As part of the Pioneer, we've attended some regional development days, and we are all talking about the same problems. And I think if we're all talking about the same problems, that suggests very strongly that they need to be resolved centrally. I think everyone is thinking about that challenge of how do you create funding flows. There's lots of appetite around left shift, and I think there's lots and lots of things that are perceived as being solvable in primary care, and I would agree with that. But clearly that comes at a cost. How we ensure that funding flows so that general practice can deliver that sustainably and do that in a way that makes sense for general practice and primary care. I think we have to have some central guidance about how is that going to happen. We all talk about technology and data sharing. They are real challenges. And the other thing that I think has been a considerable challenge in lots of places is around the comms and engagement of neighbourhood health, particularly with the stripping out of so many ICB colleagues. And I often think that when you strip these things out, it impacts primary care perhaps more than it does our colleagues elsewhere in the NHS, because, in a PCN, general practice, you can't afford your own comms and engagement people. There just isn't, and there certainly isn't the budget anymore for any of that. So how are we going to describe not just, there is to patients, but, that how are we going to tell every district nurse, every receptionist, you're now part of neighbourhood health? How do you say that to the librarians who have got so much opportunity around health and wellbeing without any resource to think about how we describe what neighbourhood health means? I think the voluntary sector could be a big part of the answer, but again, until there is adequate resourcing of that, it won't happen. So I think those are three very obvious challenges centrally. I mean, again, the estates issue, I think centrally someone is going to have to answer where is the capital and revenue coming from for these estates? Because I think what will end up happening is we'll scrabble about for a bit of estate and it will almost certainly be in the wrong place because that is where the building is. That's what we're looking at the moment. So for me, we're looking at a building that is in one part of one of our neighbourhoods. And yet within our neighbourhoods, we've got an area that was described as a left behind neighbourhood a few years ago by an all-parliamentary group. I mean, it's a terrible term, but they are neighbourhoods where there is an absence of community assets as well as issues of deprivation. So residents living in a left behind neighbourhood, even though the deprivation might be equal, the outcomes are much poorer because there are no community assets. So again, thinking about why isn't our neighbourhood health centre going there to help rebuild some of the community assets into that left behind neighbourhood? That for me will be just such an obvious thing, but there's no capital and there's no revenue. I think we've spent quite a long time thinking about some of the difficult stuff, like what is the right governance structure? How do we flow funding? And I think those are all important things. But actually, for me, the learning has come from just testing something out and finding a different way of working. And, I suppose we've tested out in some ways quite a big way with that children, young people's pilot. I think the energy for us has come with the test and that has galvanised the enthusiasm. And I think for me, building on that with something simple, just start, gather a few like-minded people. I think that for me would be the starting point. And getting people together around a table with a cuppa, imaginative, is a good place to start.
Well, that's it for this week. Thanks again to Zalan and Rachel, and thank you for listening. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news and access lots of other resources on our website at GPonline.com.